Welcome to our Care Compass project provided by the Wood County Committee on Aging, Brookdale of Bowling Green, Ohio Living, Golden Care Partners, BGSU Optimal Aging Institute, and the Wood County Hospital. This is a quarterly education series designed for those who are seeking training to learn about best practices in caregiving and those who realize the caregiving journey is inevitable and want to plan ahead. We're very fortunate today to have our speaker from the Hospice of Northwest Ohio. Our first on our agenda is Busting the Myths of Hospice and Palliative Care. We welcome Sara Chambers.
Thank you. First of all, I want to make sure everyone can hear me okay. Yeah? Okay. I want to thank Danielle and the Wood County Commission on Aging for inviting me to speak this morning. As Danielle said, my name is Sara Chambers. I am the community educator for Hospice of Northwest Ohio, and I am also a nurse. I've been a nurse for 13 years. Most of my career has been in the ICUs at Toledo Hospital and with Hospice of Northwest Ohio. So one of the, probably the most actually requested topics that I get is this busting the myths, because hospice and palliative care are very misunderstood because it's a fairly new specialty. So there's a lot of myths out there. Are there any myths that somebody can think of right off the bat that you've heard maybe?
So she mentioned the common myth is you can only have hospice if your death is imminent.
Okay, we will absolutely talk about that because that is a myth. So one of the first myths that I always like to talk about is that people think that hospice is this physical place. And in this myth, it says hospice is a place that people go to receive care. But the harsher truth is, the myth is that hospice is a place that people go to die. So the truth is, though, that hospice is actually not a physical place. It is a holistic philosophy of care. Same goes for palliative care. And the idea of holistic is you go to see, if you have heart disease, your cardiologist is really focusing on your heart, and your nephrologist is really focusing on your kidneys. You have a pulmonologist who focuses on your lungs. Palliative care and hospice is focusing on the person as a whole, and that includes things like emotional care, psychological care, practical care, things like assistance with paperwork, like living wills, advanced directives. Holistic care is considering the entire person, their caregiving situation, family situation, if there is family, and if there's not family, who is it that they consider family? So it is a holistic picture and philosophy of care. This, like I had said in the beginning, is a fairly new concept in the world of medicine. Back in 1948, this lady, Dame Cicely Saunders, over in Great Britain, England, she was working first as a nurse. She hurt her back, as a lot of nurses do, and then she became a social worker. It was during her time as a social worker that she was working in a hospital and realized that hospitals were not really set up, like the environment was not set up, and the staff were not really trained to deal with these unique issues that come up when somebody is facing the end of their life. Because hospitals were meant to heal infections, to fix broken bones, things like that, for surgery. They weren't meant for a place to relieve symptoms when we cannot heal disease. So she decided this needed to be a medical specialty, and she brought this idea to a physician friend of hers. And he told her, rather bluntly, not only are you a woman, and people are going to have a hard time listening to you, but you're not a physician. You're a nurse and a social worker. You need to become a doctor to try and introduce this new specialty or be taken seriously for this philosophy. Excuse me. So she did. So she was essentially her own interdisciplinary team, nurse, social worker, physician. She's considered the pioneer of hospice care, and she came up with the philosophy of total pain, which is a unique suffering at the end of life that includes the physical pain, it includes psychological pain, it includes social pain, and then practical sort of wrapped up in that, and then spiritual pain. During her time as a physician, she was also paramount in researching physical pain relief with morphine or opioids. Because back in the 40s, they would treat pain. Somebody would be having pain from maybe a tumor. They would give them a dose of morphine, but they were so worried about addiction, side effects, things like that, that they would basically wait until this person was then screaming again in pain before they would give another dose. Dame Cicely, or Dr. Saunders at this time, she proved that constant pain needs constant control. So you need these small doses of morphine every 4 to 6 hours so you keep this steady, small dose in your bloodstream so it's working on those pain signals, instead of a roller coaster of you get the dose, you have a little medicine in your bloodstream, your pain level starts to go down, but that medicine level starts to go down and the pain level goes up again. So instead of chasing that, she was paramount in proving that constant pain needs constant medication. So schedule those opioids. And in the dying population, things like addiction are not a risk. She also, this was one of my favorite quotes from her, is we need to relieve where we cannot heal. We know there are, I'm so sorry. We know that there are diseases and situations that simply do not have a cure, but that doesn't mean that the person is dying in 2 days. They can still live during that time, even though they have this terminal diagnosis. With relief of symptoms and the proper support, it doesn't have to be this imminent thing. So in 1963, she lectured for this lady. This is Florence Wald. She was the dean of the School of Nursing at Princeton and invited Dr. Saunders to lecture to a group of, I believe it was medical students, nurses, social workers, and spiritual caregivers, which is what Dr. Saunders requested to speak in front of. She brought this holistic philosophy, this interdisciplinary team working together for terminal patients, and lectured at Yale. And then Florence Wald is then credited with bringing hospice to the United States because she ended up creating the Connecticut hospice in 1967. In 1969, the book On Death and Dying by Dr. Elizabeth Kubler-Ross was published. And if you've ever heard of the 5 stages of grief, that's where this came from. So death and dying were really starting to be talked about in other ways. 1974, I believe, was St. Christopher's Hospice was opened as the first inpatient hospice in England. In 1979, Hospice of Northwest Ohio, I believe, was formed by a group of volunteers. No, I'm sorry, 1981. I'm sorry, I missed 1979. 1985 was when the Medicare benefit was approved. So Medicare recognized hospice as a specialty and said that that's something that they would pay for. And that was 1985, that wasn't that long ago. In 1995, our inpatient unit was built locally. This is the one in Perrysburg. And then in 2004, our one in Toledo, which is by UTMC, sort of, that was built in 2004. So these are our 2 inpatient local hospice units for Hospice of Northwest Ohio. And both of these buildings were completely funded by the community and donations. So in 1981, I think we cared for 90 patients that year. And then in 2018, by comparison, I think our numbers were, it was something like 11 or 1,400 patients and families. So we have grown quite a bit since the 80s, but we were the first in this area. In keeping with the idea that hospice is not a place, that it's a philosophy, I do want to address where is care provided. Most of our patients, so if we have a census of say 400, I would say 300 of them, 320, 330 even, are probably at home or in a nursing facility, wherever they call home. Most of our patients are at home. We have some that are in hospitals. We have some that are in our inpatient units, which is kind of like an ICU for hospice patients. We can't do things like run codes. We, of course, do not intubate people, but it is intense symptom management in those inpatient units. The average length of stay is 3 to 5 days. And sometimes people do come there for the specific purpose of dying because they don't want to die at home. Maybe there's children at home. Maybe they don't have somebody for them to care for them in their home at that time. And if that is a goal of care, that's something we try to work for too. This was one of the myths that we heard in the beginning, is that hospice is only for people who are in their final days or imminent death. And that is definitely not true. We really do our best work when we get involved early. This is nationwide. The average patient is on hospice for 2 months. And our statistics locally for hospice in Northwest Ohio is pretty on par with this. I'd say average length of stay, we look at like 67 to 68 days for the most part. But I think some of this data is skewed by those who come on very late in their disease process and are only on for a day or two or hours before they die because they have elected hospice so late. But on the other end of that, we do have a couple of patients who were on for years before they died. So average, yeah, is 2 months, but it can be really skewed one way or the other. I get this question a lot: when is appropriate to call on hospice for assistance? The most common answer I hear is when it's believed that a patient has 6 months or less to live if the disease progresses naturally. And that's what 2 physicians are saying, excuse me, when they sign and say a patient is appropriate for hospice. That doesn't mean that they're going to die in 6 months. We don't have a crystal ball. We certainly have ways to guesstimate or have a good prognosis, an idea, of 6 months or less, but that's a rolling 6 months. We do recertifications every couple of months, and we just have to prove that the patient is in fact declining, whether they're losing weight, they're getting around a lot less, maybe they're having medication changes because of pain. That's all symptoms of decline, and they get recertified for another, certification period. So don't get hung up on the 6 months. My favorite way to approach this is a question that Dr. Ira Byock poses, and he is a leading palliative care physician in the country, and it's called the surprise question. So if you're thinking about a patient who may or may not be appropriate for hospice, ask yourself, would you be surprised? Would it shock you if this person died within a year? If it's not going to be a shock to you because they've been functionally declining, having trouble taking care of themselves, had a major diagnosis, if that's not really would be a surprise, then they probably qualify for hospice. But if you're like, yeah, if they died within a year, I'd be pretty shocked. They may not qualify for hospice, but it doesn't hurt to call. The other way I explain this to people is if somebody's having uncontrolled symptoms, so they're going to the hospital a lot because they're having acute pain crises, that's something that we can help with. To try to keep them out of the hospital. We help to coordinate care with family members or even other professional organizations if that's what's needed. But I would say if somebody's having uncontrolled symptoms, and I'm thinking of maybe a COPD patient who in the last 6 months has been in the hospital like 3 times because they got real short of breath. Maybe they weren't intubated all 3 times. Maybe they weren't even admitted all 3 times. The 3 times in 6 months for the same symptom, we might be able to help there. Or if somebody has multiple diagnoses, so a lot of different comorbidities, they have heart disease and kidney disease and a touch of liver disease. That might be a time when we can help too. And the last way to explain when is if somebody's goals of care align with any of these. And I won't read them to you, but these are like goals of care. So one of them is just as simple as, I don't want to go to the hospital anymore. I want to do X, Y, and Z, with the time I have left. The next myth that I don't hear as much anymore, but it's out there, is that hospice is only for people with cancer. Again, this is national data, but our local data really aligns with it pretty well. About 30% of patients have cancer. We actually see a lot more of the chronic diseases like Alzheimer's, dementia, ALS, maybe somebody had a stroke. So sorry. Lung disease like COPD, emphysema, heart disease, congestive heart failure, kidney disease. We see those chronic diseases more often now than we're seeing cancer. So this breaks down a little more if you're a numbers person, but you see the circulatory, the heart disease, neurological brain diseases, respiratory, lung disease, kidney disease, and then other would be 14%. So 30% is cancer, everything else kind of falls into here. The next myth is that hospice care is expensive. It is covered by Medicare, Medicaid, and most private insurances. And as a nonprofit local hospice, we never turn anybody away for inability to pay, even if there is a charge that comes up. So Medicare, Medicaid, and most commercial insurances are now covering 100% of hospice services. This is a big one. This is one that I still had patients when I was a home care nurse kind of think was true. Hospice won't treat anything or takes all of my medications away. The truth is that we include any and all medications, therapies, preventative and interdisciplinary interventions that are involved in comfort. So where this comes into play is, let's say I'm going to talk about a COPD patient again, somebody with lung disease, COPD, but they come on and they also take their cholesterol medication, their thyroid medication, some anti-anxiety medication because they get anxious when they can't breathe. We're not going to take those medications away. We're actually going to pay for some of them because we're going to pay for things that are related to comfort and related to the terminal diagnosis. So for COPD, we will pay for inhalers, steroid treatments, opioids for shortness of breath, anti-anxiety medication, the stool softener you need because you're taking the opioids to help with the shortness of breath. All of that is comfort and COPD related. But that thyroid medication and that cholesterol medication, we're just not going to pay for it. A lot of people's secondary insurance picks that up. We're not going to tell you you can't take it, but we're just not paying for that because it's not related to the COPD and it's not related to comfort. I could make an argument that thyroid medication is related to comfort, but we're not going to go there. Okay. When a patient elects hospice, what's included? Symptom management is the gold standard of hospice and palliative care. And when I say symptoms, I'm not just talking physical. And that is included in not only the doctor and the nurse's care, but in the home health aid services as well. Medications, and I put a star by that. I already explained that we do pay for a lot of the medications that our patients are on. We also pay for things like wound care, medical supplies, medical equipment, hospital beds, commodes, whatever it is they need in their environment to keep them safe and comfortable. As a nurse case manager, I thought my biggest role was family and caregiver education. I felt like if I prepared the patient and the family for what to expect, their journey was a little less bumpy. And if I could do that, because I never expected to take the pain away, right? But if I could make it a little less bumpy, that was my goal. Emotional and spiritual support come in the form of social workers and chaplains, both in very different ways. Occupational, physical, and speech therapy, if needed, to enhance quality of life. That's right, we would do physical therapy, but we can't, that's goal driven. So we can't have a patient, again, I'm just going to say COPD. We can't have a COPD patient who says, I want to get stronger, so I need physical therapy. No, we don't expect you to get stronger with or without physical therapy at this point. But if you need physical therapy to help you figure out how to safely navigate in your home with a walker or getting up out of bed, or you want to be shown a couple of exercises to help you strengthen at home, that can be done. That's goal driven. But it's not going to just be, I want physical therapy for the sake of physical therapy. Massage therapy is also very popular among our patients. Volunteer support is, I couldn't even list for you the number of things that our volunteers do for us. They're wonderful people. Assistance at the time of death. So the death visit, when a patient dies at home, as the nurse, I would go out, pronounce the patient, call the physician, and then I take care of all of the practical things that need to be done, calling the funeral home, cleaning the patient, putting them in the clothes that they want to go to the funeral home with, packing the meds, getting everything ready, while the family that's left behind can be family, and they can grieve and they can support each other, and we're doing the things that need to be done. And then bereavement support. To me, this is one of our gold standards because Medicare requires hospice programs to have some sort of bereavement support, but they don't tell you how to fulfill that. So some of our competitors, they fulfill that category by handing somebody a pamphlet on grief at the time of death. That's bereavement support. We choose a little bit of a different path. We have 5 or 6 now professional bereavement counselors, And I quickly have a personal story. This is my first touch with hospice in Northwest Ohio was with bereavement support. My best friend was killed when he was 25. I was 28. And he was not on the hospice program, but somebody told me they offer free grief support to the community. And I went, this was 9 years ago. And they helped me a lot, and he wasn't even on the program. So we continue to do that. We have different types of groups, different types. There's one I know, yoga for grievers is pretty popular right now. Virtual, of course, is big. In person, private chats, group settings, what have you. We have a very robust bereavement program. I forgot to click to this slide when I mentioned symptom management as our gold standard, because I said symptoms are not just physical. That red box there, those are physical symptoms, a small list of physical symptoms that could happen to somebody as they approach the end of their life, whether this is months, weeks, days, or minutes, before. But the red is physical, and our nurses and doctors kind of help with those symptoms. That green box to the right of it, the emotional support, caregiving support, experts at community resources, and financial support, those types of symptoms are helped by our social workers. The blue box, emotional and spiritual, is our spiritual caregivers. And that doesn't mean religious. They're non-denominational, and it's one of the biggest questions that comes up with patients is, why me? Why is this happening to me? Kind of thing. That's a spiritual question and may or may not have anything to do with religion. And then the last, certainly not least, is the yellow box, which is ADLs are activities of daily living, which are the things that we have to do every day. We have to clean ourselves, we have to eat, we should clean up our space a little bit, things like that. These are things that our nurses' aides help with. And I include weakness and fatigue as symptoms with the nurses' aides because I often tell people they can really help with those two symptoms. And those two symptoms happen to every patient, no matter their disease process. They are going to get weak and they're going to get tired. So if you think of your energy as money in the bank when you wake up at 7 a.m. and you need $30, you have $100 with energy, but you need $30 just to make yourself breakfast, go to the bathroom, get a little cleaned up, make yourself and eat breakfast. If we can save you $20 and get a lot of that done for you or with you, maybe you can use that $20 worth of energy later on to play a game with your son, or go to the park, or do something you want to do instead of those things that you have to do, because energy is kind of finite, right? So if we can help you with that, that's how our nurses' aides help with those symptoms. So that's all included in the program when somebody elects hospice. Once a patient is on hospice, they can't come off. Totally not true either. People graduate. People actually come on, get better, and they don't qualify anymore. But I see that with Alzheimer's, heart disease, not cancer, of course, but sometimes this does happen. Or they come on, we make some med adjustments, get rid of some meds, they have a little more quality of life, and they're doing better. So they come off and we release them back to community physician or whatever and say, call us if you need us again, but you're kind of doing too well. That totally happens. Patients can always change their mind. We'll also have patients who elect hospice and then 2-3 weeks later decide, no, I want to go back and I want to go more treatment, more therapy, whatever. Okay, you just sign a piece of paper, you go back to that. That's fine. This is not a, once I make this decision, I can't change my mind thing. I talked about graduation, and then revocation means I've decided to stop my hospice benefit, whether I want to seek curative treatment or I'm moving and I'm no longer in this area for you guys. So I'm going to elect a different hospice. Another myth is that you need a physician referral to come on hospice. You do not need a physician referral. A lot of times people will call and say, hey, you took care of my mom 3 years ago and my dad hasn't been doing well recently. Can you guys come take a look, see if he's eligible? That's all it is. We have to have 2 physicians certify that the patient is appropriate for hospice. But that's on the admission nurse to make those phone calls. And sometimes it is the patient's physician making the phone call and saying, yeah, they already feel like they're ready. And then our physician is the second and they sign it and we go. But it just depends on the circumstance. But you do not need an official referral to come on hospice. 419-661-4001 is our 911, our line for everything. How you set up an appointment or consultation, or you're just talk to somebody about hospice and palliative care. And it can be from anyone, the actual patient, it could be a caregiver, family member. We get calls from physicians to ask questions too. Oh, this is the one that really hurts my heart sometimes when I hear this. Hospice uses medications to hasten death. So not true. We do not utilize any interventions to hasten death or to artificially prolong life. We let it happen as naturally as possible and only intervene when a symptom appears to be causing distress. Not everyone ends up on opioids, but I would say a lot of people end up with pain. This is another one that goes along with that idea, and that I have a lot of older folks, when I would start to talk about morphine for pain or shortness of breath, they would get really, really nervous. And I understand that. It's a scary word. You hear a lot of bad things, in the news and stuff. So they're saying, no, morphine kills people. This is a myth, okay? I will agree that morphine has the potential to kill people. Fine, let's make it grammatically correct. Morphine has the potential to kill people. I agree, okay, fine. It has the potential to. So does Tylenol. When I was working in the ICU at Toledo, I had 3 patients in my 5 years that tried to kill themselves with Tylenol. Insulin has the potential to kill people. You can overdose on insulin very easily. Alcohol. My point is, when used correctly at the direction of a physician, it's not dangerous. Just like Tylenol, when used correctly, insulin, when used correctly, alcohol, that's debatable. When used in moderation, whatever. But my point is, morphine doesn't just inherently kill people. Another myth is that all hospices are the same. I talked a little bit about how Medicare requires certain things, but doesn't really give you information on how to meet those requirements. So all hospices do it a little bit different. Bereavement being one of those things. So Medicare sets the guidelines, which we all have to meet, but the degree to which required services are provided can vary greatly. And it changes. I feel like it changes week by week, but I gotta imagine there's 10 other hospices in the area besides us now. The difference between us, though, is we were the first in the state to be licensed. We're the only independent nonprofit that is solely dedicated to this population. And we were named one of the top 100 in the nation. We have 6 dedicated physicians, so this is their job. They don't have practice on their own and do this on the side. They round in the inpatient units and they oversee our home care teams. This is their career. We have 8 APNs or NPs, and our bereavement program is by far the most extensive and accessible for the community. It says 4 here. I need to change that because I think it's 5, maybe even 6. These numbers are a little old, but I can't imagine they're too far off. They have to do these for Medicare. So when somebody goes through a hospice program, their family is sent a survey, just like when you go to the hospital, you're sent a survey. The national average for hospice programs is 81% to get a 9 or above, and our average is 84, so we're just above. And then the question, would you definitely recommend? National average is 84, and we're closer to 90. This, to me, is the big differentiator. Especially certified staff. So I don't know if you saw my credentials on the very first screen. It says BSN, RN, CHPN. So BSN, I have my bachelor's degree in nursing. That's the 4-year. The RN means I passed the Ohio State boards and passed the NCLEX to prove that I was safe enough to be a registered nurse. CHPN is kind of like that. It's the boards for certified hospice and palliative care. And I gotta say, it was harder than the NCLEX. You have to take that test and then recertify every 5 years, and it's expensive. They have the same certifications for med-surg nurses, for ICU nurses, for pediatric nurses, whatever, all the same idea. You pay to take the test, you have to study a lot for it. Well, when I first started with Hospice in Northwest Ohio, they said, once you hit your 1-year mark, we're gonna have you start going to class, we're gonna pay you to go to class and study, we're gonna pay you to take this exam because we want our staff to be certified. We want our staff to be the best. So a couple years, I think our number is 74, 75 now. A couple years ago, though, it was 73% of our nurses and hospice aides are certified in this specialty. Patient and family testimonies. The biggest thing that they tell me they love about being on hospice is no more doctor's appointments, and that they feel like they have this like support system or this peace of mind. They can call us at any time. We're 24/7. A nurse is always available for a visit. And they felt this peace of mind in the fact that we could normalize a little bit of this journey for them. Last myth I want to cover, palliative care is the same thing as hospice, or vice versa, hospice is the same as palliative care. I can say, yes, hospice is palliative care, but palliative care is not hospice. Hospice follows this palliative care philosophy of wholeness. So all hospice patients are receiving palliative care, but not all palliative care patients are receiving hospice. The biggest difference is a palliative care patient can still pursue curative treatment, but get the benefits of this holistic approach from an interdisciplinary team. Hospice patients, once you elect hospice, there's no curative treatment involved. It is focused on symptom management and comfort. That's the biggest difference. So, but palliative care, you can be on chemo, radiation, all of it, and take advantage of a palliative care program. Again, hospice is palliative care, a part of palliative care, but palliative care is not hospice. Here's a couple of lists. So palliative care can begin right at diagnosis. Hospice more begins when curative treatment has stopped. But they both offer this symptom management, this holistic piece. They both try to reduce stress for the patient and family, and they both provide that total pain picture of support. We do have a palliative care program called Sincera. We're very lucky in the community to have this type of program that is sort of supported by the arm of hospice of Northwest Ohio. So we do have a totally separate palliative care program with NPs and physicians and all of that. All right, I'm going to stop sharing my screen. I think I left about 10 minutes for questions before lunch. And I need a couple of drinks of coffee. So sorry.
Perfect. Thank you, Sarah. I'll open the floor to anybody that's actually at home as well. So if you want to unmute yourself and go ahead and ask a question, we'll start with you there. All right, looks like no questions from home. We'll go ahead and open the floor to anybody here who may have a question. Yes.
So I'm more interested in the palliative care portion. I mean, can you speak, once you can speak again, Sarah, I'm so sorry. But if you could speak to the how that works, I mean, what that actually offers that's outside of hospice, because I know they're a little bit different. Like if my father has Parkinson's and he's in a place where now he's not doing as much, he's not maybe end of life, but we need more assistance. Like how would that work?
What would that look like? Did you hear that okay, Sarah?
I think I heard like what would a palliative care picture look like for somebody who was in a facility?
Correct. Who may have a diagnosis of Parkinson's disease.
And they're at home.
They're at home.
Oh, they're at home. Either or though. Okay, yeah. So palliative care. I'm assuming if the patient has Parkinson's, they probably have a neurologist. They probably also have a PCP, a primary care provider. So at least two physicians involved in the care of this patient. What our team can do is, of course, with permission, we come in and we have what's called a goals of care conversation. How are you doing functionally now? You know, what do you, and we have specific prompt questions to kind of pull themes of what these patients are looking for to give them the most amount of support. We access the medical records, look at all the medications, recent hospitalizations, talk about the symptoms, whether that's physical or caregiving, talk about the symptoms that are, you know, top 2 or 3 at the moment. Then our NP and physician or physician can visit the patient, whether they're at home, in a facility, or a hospital, have this conversation, and then make recommendations, and also be an advocate and a go-between for those other physicians involved in the case. Because historically, doctors are just not great at talking to each other, right? Your cardiologist makes changes or your neurologist makes changes, and they don't necessarily communicate that to the PCP. They're not always on the same page. That's what we're doing, coordination of care. But in the meantime, we're not just focusing on the Parkinson's. We're going to try to plan for potential losses ahead, whether it's loss of independence, physical, loss of the ability to walk, who knows? But those are the things we're going to try and advocate for, to talk about, to, like I said, pull themes from the patient about what's important to them at that moment and beyond. Assistance with things like advanced directives. So palliative care is going to look at that Parkinson's patient, at their physical symptoms, but also how that Parkinson's is affecting them emotionally, socially, practically. And our social worker can help with community resources, can get involved with for counseling purposes. I mean, it just kind of depends on the needs of the patient. But the palliative care team ends up being this great sort of go-between. And we have the time to have all these important conversations where when you go to the physician's office, I mean, they're booked like 10, 15-minute visits. And they got to keep going because they have so many patients. But we build in the time for you to ask the questions about the medication, the disease process, the tests that your physician just told you about and you talk to them about, but maybe you only retain 25% of that information because you're emotional. Well, our team can look at those tests and explain it a little more thoroughly and talk about what that means in the moment and moving forward. Did that answer your question?
It did. So you still do, I mean, you're still going out to your specialist care, you're still seeing those doctors, but you might be getting more assistance at home. And you can help determine if there's some needs at home.
100%. You got it. Yes. Kind of like, we're a supplement, but also an advocate. And the biggest difference between the two programs, when I think about like the interdisciplinary team, palliative care doesn't have hospice aides. So there's no nurses aides to come and help with the activities of daily living for palliative care. The aides come in for hospice. But that doesn't mean there's not other aid services that can help if nursing aid is an issue. But that's one member of the interdisciplinary team that is not on palliative care.
So home health is needed for like PT or
so all of that would be coordinated.
Or ADLs, that's not part of palliative?
That's not part of palliative. If somebody needs activity of daily living help and they have a diagnosis and they want the assistance with palliative care, we can certainly do that, but we don't physically have aides for palliative care. But I mean, we can come up with a list of people that do provide aid services.
Thank you. I think we have another question in the back. Yes. My father went into hospice about 7 weeks ago in Michigan, but I guess you should know, my mother was at the depression. Now it's that hospice home. So I'm not sure if you heard that all clearly, Sarah. So her father went into hospice 7 weeks ago in Michigan. And she was under the impression that hospice would come into your home, but they did not. So they do 4 hours a day, twice a week.
Oh, so you were under the impression that hospice would come to your home and stay there as a care for like days at a time.
Yeah, he doesn't walk. And my mother, she's 93, my mother's 85, and she can't lift anymore. Yes, it sounds like his mobility is an issue, and so the mother cannot lift him. There's other concerns.
Back in the 90s, we were set up to be able to provide that type of care. But as Medicare started taking over a little bit more, they don't reimburse us to be having nurses or aides in the homes for full days.
There was a-
So
You did do that, so that's why they had that question, I guess, from back in the day. That you did do that.
So she said there was a point where you may have done that in the past, and that's why people have that impression. So, yeah,
absolutely.
the rules of Medicare and Medicaid do change quite a bit, so that's why it's good to keep up on them.
So then hospice pays for his medication and it's fair that they don't pay for where he stays.
Hospice pays for what?
They don't pay for where he's staying and then it's just living.
Correct. So we would not be paying like room and board at a nursing facility.
Okay.
That's the responsibility of the patient.
So she's saying only at a hospice directed facility, a hospice specified facility.
Would it be paid for?
Correct. She's asking that.
Correct. But in order for that to be paid for, that person has to be in an acute crisis. Those units are used for symptom management crises. So nobody really comes and stays for weeks, months, years at a time until they die and are just cared for there. That's not how they were set up. There are certain, we do have it gets cloudy because we have this wing called alternative home care, which is essentially a nursing facility in a wing of our building, one of our buildings. And that's what it's set up for, but people privately pay for that. We're not paying for room and board. We don't pay for room and board for anyone. If you're admitted into the inpatient unit for symptom management, that is paid for. But once those symptoms are under control, the idea is you go wherever you call home. And we're not a 24/7 physical care service. We're available for visits. Visits usually last an hour or two. Nurses aid visits are about an hour and a half. But it's not a service in home care where we're there all day, every day. Now, if there's something going on and somebody's having symptoms, there are ways, there's called, crisis management at home, and we might be in the home for a while getting that symptom under control. But day to day, we are not providing hands-on care day to day because they don't reimburse us in that way anymore, unfortunately, because I'd love to be able to just go in and just care for somebody day in and day out, but it's just not set up that way, unfortunately.
$30 an hour, and I did the math on that, and that was $5,005 a week. And the person says, "Oh, never mind, because they don't have enough help." And so understaffed, no one else is done anyway.
Yeah. She was just talking about the complexity of staffing.
It gets really, really, really dicey and scary when you start talking about nursing facility versus staying at home and hiring a private, because from what I've seen, a lot of these private, they're just not as reliable. Sometimes people get hung with nobody coming in for a day. And then you think of the nursing facility route, both of them are very expensive. It's hard to navigate, but there are people out there who can help with the resources to try to figure out the best situation for the patient and caregiving. It's just, we can't provide it all the time.
Perfect. Thank you, Sarah. I think at this time, if there's one more question here, and then we'll go ahead and break for about 5 minutes for lunch. I'll hand out their lunches and we'll start the second half.
All right.
My husband is in a long-term facility. And would hospice step in there? And right now he just sees the facility doctor and nurse practitioner.
Yes, so we could see him there, and what would happen is his nurse case manager would see him 1-2 times a week. We would work with their staff, work with that facility physician, which we do a lot. Sometimes the facility physician will say, now that you're involved, you guys handle the symptom management. So anything involving pain, shortness of breath, anxiety, but maybe they're going to continue to handle the day-to-day meds, like the metoprolol and the multivitamins and the thyroid meds. But they want us to handle the symptom management piece. So we work together with the physician in that long-term care facility. We also send aides in, which the facilities love because our aides help out their aides, to give good bed baths, to help with meals, whatever. So you get the full services of home care in a nursing facility, because that is still considered your home. I mean, that is home care to us. We have home care teams that are dedicated to nursing facilities. So I actually stepped into the home care role for the nursing facility team for a short time. And I was assigned, 3 or 4 facilities that I was basically in charge of. And I was going to visit those every day as the hospice nurse, pick and choose who I needed to see. The nurses there got to know me, would ask me questions about death and dying or about hospice or whatever. And we provide this supplemental care to that patient, the staff, the family. So yes, we do go into long-term care facilities and then work with the attending physician there. He's still involved, but depending on the attending, like I know some of the facilities automatically say, all right, you guys take symptom management, and other facility docs will say, I'll take your recommendations, but I'm going to write the orders. That's fine too.
Perfect. Thank you, Sarah. We're going to go ahead and just take a little 5-minute break, hand out our lunches, and then start our second half.
All right.
The second half of our presentation today is entitled Dying to Know What to Expect When Death is Near. Please welcome back Sara Chambers, nurse from Hospice of Northwest Ohio.
Hello again, and thank you. So I have to explain a quick caveat before this program. This was created for professional caregivers, and I present this to other nurses and nursing facility nurses to try and normalize the dying process for them, because they don't always understand what's going on when somebody's dying and what's normal and what's not. So some of the advice that I give in this is for professional caregivers. And if it's something that like you found yourself not doing or you don't think you can do, don't beat yourself up, because this is meant for really the professional audience, but I think it's great for non-professionals as well. So this is my CE stuff for when I talk to nurses and social workers, and I have to explain to them my objectives. So we're going to talk about physical changes relating to dying, nutrition and hydration needs, which is always a tough subject, the importance of normalizing and how to normalize the experience of dying, and how to assist patient caregivers and their loved ones through this journey. So I always like to start presentations, especially to my colleagues, my professional colleagues, with something like fun or interesting facts. So the Danse Macabre is also called the Dance of Death, and it's an artistic genre that dates back to the 1400s. The earliest recorded scheme of death is actually lost now, but it was at the Holy Innocents Cemetery in Paris. This genre consists of depicting death or the dead, and it summons representatives from all walks of life to dance along with the dead. Usually a grave, typically there's a pope or an emperor, maybe a king, sometimes there's a child. Women were actually rarely portrayed in this type of art, but the point of this art back in the 1400s was to remind people of the fragility of life and how vain the glories of earthly life really are. So it symbolized this universality of death, that it happens no matter how rich or poor you are, no matter where you came from, your skin color, whatever, your station, it doesn't matter, your age, your accomplishments, how rich you got. This dance of death, the Danse Macabre, unites us all. It's just something that we all have in common, right? Ivan Turgenev was a Russian writer, and I love quotes, and this quote is, "Death's an old joke, but each individual encounters it anew." And I like to remind our new hospice nurses that no matter how many times you go through it with a patient, it's their first time. We have seen it time and time again. We walk the path with people, the journey through death, time and time again, but no matter what, this is the first time they're going through something like this. So they have to keep that in mind. So with that being said, a good death means something to everyone. Everybody's definition of what this is going to be different. And we only have one opportunity to get it right for somebody, to get it right for them, to get it right for their family, because the way that you care for somebody at the end of their life and the way that they die ultimately affects the people around them, and it shapes their future decision-making when it comes to life and death and how they approach their own death later. So our thought is a good death honors the person's entire life. And we think by understanding what to expect throughout this journey, the patient and family and the professional caregivers will be better prepared to promote comfort. It's our job to educate, but they might turn to a more trusted friend than they will a nurse, maybe. They might turn to their nursing facility nurse that they've known now for 2 years, even though they just met me. They might ask her questions. So they trust her, and they're going to go to a trusted source. So we want to equip them with how to talk about death and dying. Fear, misinformation, and lack of information are always barriers to education, right? They all negatively impact decision-making and the dying experience. So how do we bring meaning to this experience, to a good death? I encourage people, one, to think about their own death. I know it's not easy, but if you could choose when, where, and how you died, what would that look like? No, you can't say, well, I just wouldn't die, because it's not an option yet, right? But I've often thought about it, like, what is the peaceful way to go for me? I kind of want to be outside with the sun on my face, honestly. Breeze going past my nose. These are principles of a good death, and this came from the authors who wrote The Future of Healthcare of Older People. I'm not going to read them all to you, but a good death basically goes beyond physical symptom control, which is sort of what we talked about in the concept of total pain and the history of hospice, right? It's beyond the physical symptoms. Although pain control is usually the number one goal of people for a good death. Like I said, there can be no cut and dry definition of what a good death is because it means something different to everyone. It's whatever brings the patient and loved one meanings. But if you read through these, there's kind of themes that sort of emerge about what a good death is. And I think the themes are sort of all boiled down to having control, having some autonomy in a situation that feels like it's out of control. So as a care team, we can make this happen. We can help people realize and reach their goals to what they see as quality of life. But in order to do that, we have to give them permission to talk about what they're scared of, to talk about what their fears are, to talk about death, which is hard. And it's hard to create that safe environment to do that. But man, when you do, it can be very powerful. So we have to be open and honest and willing to talk about death. Tani Badi, this is her dad. Tani Badi is a hospice and palliative care nurse that I look up to. In fact, she spoke at our Referral lecture recently, and she was phenomenal. This is her father, Tom Badi, and he came up with the quote that we admire the death of leaves, why not our own? And if you think about the fall time, which is approaching, we really do admire those colors. But what is really happening when we get those colors? The trees are dying, the leaves are dying, not the trees, right? So there is something beautiful happening in that demise. And the point is, we can find something beautiful in death. I've seen some really meaningful moments as people die. They become more open and vulnerable. It seems like the clutter of life, the noise of life gets set to the side, and people tend to focus on what's most important to them. That experience can and should be valuable for the family. So how can we honor that? The body has an internal wisdom. It knows how to die in a very protective way. It shuts down in a very protective way. When I asked you how you wanted to die, most people would say, well, I want to just die in my sleep. That kind of is what happens for most people. About 20% of the population will die from something sudden, but 80% of us have a battle with some sort of disease and die with a decline. And that's what happens. You eventually die in your sleep. But we have to pay attention to our patients' body's signals. We also have to understand that weakness and fatigue are expected, and we can't push back against that because we're just hurting the patient. There are certain interventions that can actually complicate this natural dying process and can hasten death, like tube feeding. People think when somebody stops eating, we have to give them tube feeding, but that can actually hasten death. If they can't handle that tube feeding, they're eventually going to fill up with it, aspirate, and die. So you have to think about the body's internal wisdom. And you not only have to recognize what's natural and normal, but you have to be able to convey that to the family and the caregivers as well. We have to be able to distinguish that there are certain symptoms that are normal when you're dying that look really, really normal when you're not dying. They look really abnormal when you're not dying. So there's a couple of different patterns of decline. The first one being the slow decline. This one is the least surprising to people because this patient has sort of gradually been declining over a long period of time. Everyone recognizes that their quality of life has slowly diminished. They're tired. They have multiple factors that adversely affect their health, and they're just taking this slow, steady decline. There's also the patient who does the stair steps, and this reminds me of heart failure or COPD maybe, where you have this baseline and then you have this acute on chronic episode of shortness of breath or chest pain, and you're admitted or have interventions for a little while, and then by the time all that's over, your baseline, you're not quite back up to here with like energy and function. And you have a new baseline for a while and you're chugging along and doing okay, and then there's another acute episode, and this kind of just happens until you die. So there's the stair step. It's, you have these plateaus and then you require a little bit more treatment. And because we're, as a society, have gotten so good with treatment options, sometimes the patient is a lot sicker than they appear because their symptoms are almost masked, right? That's this patient. Tightrope on a windy day. These patients are super, super sick. They often have multiple different organs involved with disease. So they have heart disease, lung disease, kidney disease. But because they've had these diseases managed super carefully throughout their life, physicians kind of have been able to balance the various health risks for them. And then families don't really see how sick the patient are because they don't look that sick outside, but inside they're very, very sick. So somebody might even have a small medical episode that immediately becomes terminal because they were that close before with all of these multi-organ. So a gust of wind can just knock that tightrope walker right off. The last one is the cliff effect. Modern medical care can certainly work wonders to keep seriously ill patients alive. Same idea though, the disease continues to progress. Treatments and medications continue to kind of keep it at bay, masking the patient's decline. And then all of a sudden, when the disease outpaces that great medical care, the patient goes over the cliff with little or no warning. And this is very hard for the family. They're left wondering what happened. Functional status is almost always a really good indicator of decline. We talked a little bit about activities of daily living, what our hospice aides help with, eating, bathing, dressing, toileting, just getting around, the things we have to do. I see this a lot in nursing homes, and I think it's changing. I hope it's changing, but I think of the patient who used to walk to the common room for lunch every day. And we have a tendency there's a day where that person's like, can you just push me in the wheelchair? I'm tired. No, you've been doing this all along. Keep going. Let's do this. Let's walk. Let's use your walker. So we push them to walk out of a good place. But by the time they get down there, they're too tired to even eat their meal. We have to remember that there's a lot of work going on inside. These patients are going to sleep more regardless of their medication. Their energy levels are going to fluctuate day to day. And I always tell people, you're going to have good days and you're going to have bad days. And you might have a really good day where you feel like you have all this energy and you accomplished all these things, and the next day you are wiped out. That totally makes sense. because there's so much going on internally. And we talked about weakness and fatigue are expected when we talked about nurses' aides and how your energy is like money in a bank. There's a lot of work going on internally. If you think about maybe just think about one organ, the heart. As people start to decline, their heart rate, resting heart rate, will start to rise up. A normal resting heart rate is 60 to 100 when you're sitting at rest. And someone who's declining, their heart rate inevitably starts to go faster. That heart starts to work harder. So their resting heart rate might be like 120. That's normal for them, but then you start pushing them to do more and you're pushing that heart to go up to 180. So that's where baseline vitals and getting to know the patient earlier rather than later is really helpful for the healthcare team as well. Level of consciousness. So this is something I tried really hard to hammer home with the direct caregivers and the family members of the patient. Level of consciousness is how alert someone is. So you and I right now are in LOC1. We're awake, we're alert. Nobody needs to be jabbing us to stay awake. Nobody needs to be keeping our attention for us to stay awake. We're awake. LOC2 is that person who can have a conversation with you. They just kind of appear sleepy. And then when you stop talking to them, they fall asleep after a couple of minutes on the couch. They need a little bit of stimulation to kind of keep them awake. And LOC3 is somebody who's pretty much sleeping 18 to 20 hours a day. The only way to get them to wake up and have a conversation with you is maybe a little bit of physical stimulation. I mean, they need you to be talking to them and touching them in order for them to respond to you. And then LOC4 is comatose. This person cannot respond verbally, cannot open their eyes, they are unconscious. So of course, as somebody declines, their level of consciousness goes down. I don't think I've ever seen in my career somebody come back from an LOC4, but I know there are stories out there about the rallies and things. But I have seen quite a few people sort of teeter-totter between 1 and 3. They'll get down to a 3 and I'm like, oh, I think they might be dying soon. And then they surprise me and come back. I mean, everybody's so different. But if you ever heard a hospice nurse talking to a physician on the phone, they'll say, no, they're like an LOC2 plus, or we're coming on LOC3, or they've been LOC4 for a few days. That's what we're talking about, is their level of consciousness. So as somebody is declining, if they are 1 to 3 months, and I have an asterisk here because eating and drinking less can actually start years before somebody dies. But 1 to 3 months prior to death, usually people start to withdraw from things that they like, start to talk to family and friends less, just withdrawing a little bit as a protective mechanism, or they're tired. They tend to start to sleep more 1 to 3 months out. Now, when we're getting 1 to 2 weeks closer, maybe they're starting to show some confusion because their oxygen levels are not that great in their brain. They're not perfusing as well because their body is slowly declining. Their kidneys aren't working. Maybe they having some skin changes. They're not taking in or eating very much at all. They're not peeing much. We still want them to pee and poop though. They might be talking to somebody who's not in the room. Symbolic language would be like somebody who's already at their house and they just say, I want to go home. The symbol meaning home. Mama, often people, it's very symbolic to call caregivers mama, even though it might be their wife, they start calling them mom or mama. That's symbolic. The pulse fluctuates, but usually it rises first as the heart starts to work harder, and then it starts to slowly drop. Blood pressure usually decreases, depends on the disease. Skin color changes. When I say your body shuts down in a protective way, it will try and save that its perfusion, its blood supply, its oxygen and nutrients for the heart, the brain, the lungs, the vital organs in the chest. So it'll start sort of shunting blood away from our fingertips and our toes, because it's like, I don't need the toes to survive. I don't need my fingers to stay alive. I need my vital organs. So then the tips of your toes and the tips of your fingers maybe start to feel cool or get a little ruddy red, maybe even blue, because it's not getting enough oxygen and your body is starting to shut down. Some irregular breathing can happen in this stage as well. Days to hours before death, Further discoloration of the skin, of course, because again, your body doesn't care about your arms and legs anymore. Restlessness, agitation, maybe you start to see this, somebody who's laying in bed and they're like, I gotta go to the bathroom, and then they lay back down. I gotta sit in the chair. I want to go back to bed. I gotta go to the bathroom. I want to go back to bed. I gotta sit in the chair. That's restlessness, agitation. Sometimes that has a physical cause, and sometimes it is misfiring in the brain. Difficulty swallowing almost always happens. I feel like this happens before days to hours, but always in days to hours. And we can still medicate people even if they're having difficulty swallowing. Ongoing changes in breathing, different patterns of breathing, depending on how the brain is being affected or if there's lung disease. The rattling breath sounds and terminal secretions. If you've ever heard somebody use the term the death rattle, that's what they're talking about. Because the patient is in, and it's always a comatose patient, you do not hear the death rattle, which I hate that term, but you don't hear that in a conscious patient, okay? That in order for it to be a true death rattle, it has to be somebody who's unconscious and they can't swallow or spit out their oral secretions, which are still secreting. So it just pools in the back of their throat and you hear that noise. We, especially in recent years, have gotten away from treating those terminal secretions because the medications that are used to treat those, they don't help what's already there. They prevent it from getting worse, but they also have a lot of side effects. And terminal secretions usually bother the family more than they even bother the patient. They're usually not bothersome to the patient because they're in a coma. At this point too, within days and hours, there might be no urine output at all or very dark, tea-colored, maybe smelly urine because it's super concentrated. And sometimes people's eyes are what we call half masked, so they don't close completely. They're just a little bit of the eyeball showing, totally normal. They just don't have the eyelid muscles to close it all the way. Here's a couple of the breathing patterns that we see towards the end of life, all totally normal. It just depends on, again, what part of the brain is being affected at this point. Some people will breathe even and slowly. Some people will breathe really, really fast and shallow. As long as their face looks relaxed, they don't have this like furrowed brow, they don't look like they're in distress and restless, all of these are normal. Shane Stokes is the one I see the most, which is one big breath, and then a medium breath, and then a short breath, and then no breath. And then it starts all over again. It's like this big breath, small breath, small breath, small breath, no breath. And it's a pattern. People can actually go 20, 30 seconds, a whole minute without breathing and then start breathing again at this stage. We've had people call and say, I think they died. Oh, they just took another breath. It's happened. So within minutes, or as we're approaching minutes of death, you'll see those longer and longer pause and shallow breaths. And the facial muscles are no longer like controlling all of this up here. So the mouth sort of sinks open in a very, it's not just this mouth open, it's a very unnatural looking open. Like, you know it when you see it. These muscles also let go and somebody's temples might sink in and then they look like a lot thinner than you remember. And of course, they're absolutely unresponsive minutes prior to death. So one of the hardest conversations to have with family members, caregivers, is when somebody stops wanting to eat or drink or both. And Tani Badi, who I mentioned before, says they're not dying because they're not eating. They're not eating because they're dying. And this is really hard because food is comfort. Food is love. We celebrate with food. Sometimes we commiserate with food. But as somebody's dying, their energy needs are not the same. Things don't taste the same. Their desire is going down to eat. Their ability to digest and process that food changes, which is why their desire is going down, because their body is saying, I can't concentrate on digesting all this food when I'm trying to keep everything else alive. And if you think of a car in a garage, it's not going anywhere very often. It doesn't need a whole lot of gas. So somebody who's bedbound, they might sustain themselves on a bite or two a day, and that's fine. Force feeding people is what's not okay, because it can hasten death. and make them feel worse. But before you automatically assume that the person is just getting closer to dying and that's why they're not eating, you have to assess, are there bowel changes? Are they constipated? Because if you've ever been constipated, you certainly do not feel hungry if you haven't pooped in a few days. Have they been nauseous or vomiting recently? Do they have a GI bug? Is that why they're not eating? Did they start a new medication that could affect their appetite? Altered mental status? Have they kind of forgot how to use a fork? Maybe if you fed them, they would eat, but they're not going to sit there and feed themselves. Altered oral health. Do they have thrush infection in their throat and it's making it painful? And I'm thinking of Alzheimer's dementia people who can't tell you that. You don't want to just say, oh, they're not eating, they must be dying. Let's look in their throat, make sure they don't have a tooth infection that's making it painful to eat. So I said, again, across the board, don't just assume that because they don't want to eat anymore, they're dying. We have to look at all of those factors, but force feeding certainly is not the way. So what we want to continue to do is offering their comfort foods, but always consider textures. So I tell people soup is like a hard thing for somebody who is confused or approaching the end of life to eat, because they've got to handle the liquid and they've got to handle the chunks or whatever. So it's two different textures in there. Try and keep simple comfort food, make it enjoyable, make it social with other people. If it's possible to get them up out of bed into a different environment to eat, that can be helpful. Don't put too much on the plate because that can get overwhelming. So offer small and frequent meals. Supplements like Ensure and things are great for a snack, but you have to be eating enough and drinking enough for those supplements to make a difference. And they have to like them. Artificial nutrition. So there's a couple of different ways to do that. And I talked a little bit about how tube feeding. So if somebody's starting to have difficulty swallowing, not eating as much, and their family wants artificial, like a peg tube in their stomach, we got to talk about risks and benefits of that and the goals of care. Somebody who's maybe had a stroke and is bedbound and you have a tube feeding in them, maybe they used to be able to handle 200 mLs of their tube feeding material, and now they're down to 50. That's fine. Their body's handling less. We're going to titrate down on nutrition, but the other option is TPN, which is total parenteral nutrition, which is through your veins. But again, you have to think comfort versus burden. There's a lot of studies out there that show that tumors feed off of our food, basically, when we have a tumor. And so one that I read was a woman had a tumor in her abdomen and she did not want to stop her TPN. And as they're drawing nutrition labs, which you have to do when you're on TPN, they're noticing this tumor is just getting bigger and bigger and bigger, but she's losing weight and her nutrition labs are not keeping up with what they're putting in the TPN because the tumor was taking it off from her. So at one point we have to think, are we feeding the body or are we feeding the disease? Oftentimes, the first thing that people don't want is like meats and fruits and veggies. And taste buds seem to change. I've seen people who never drank soda in their life all of a sudden like love the taste of Pepsi. And when the body is not eating, it actually starts to use fat and muscle as an energy source. This is the basis of the keto diet. The process is called ketosis. In advanced cases of ketosis, like the end of life, the nervous system response is actually dulled, which helps with pain control. And then patients rarely feel things like pain, hunger, or thirst. Endorphins are also produced, and they've seen this in studies, that give patients this overall sense of well-being or like a mild euphoria. And if food is introduced or forced at this point, it can interrupt that process of the ketosis and the endorphins. So what can we do is recognize that this is just another loss. First, maybe mom and dad or mom or dad had to be moved to a facility. So they lost their independence. That was hard enough. And now you're saying they don't want to eat and that's okay. Yeah, it is, but it doesn't make it any easier. Of course it's so difficult. Recognize that this leaves the family feeling helpless. They don't know what to do. They think if I go home and make mom's favorite chocolate cake and bring it in, she'll definitely eat it. And then when she doesn't, they feel rejected. The daughter is like, oh my God, she's rejecting me, not my chocolate cake. And she's not even rejecting the chocolate cake. It's just, it would make her sick. When people say to me, aren't they starving to death? Starving is a very emotionally charged word. It refers to someone who would eat and who wants to eat, but can't. People at the end of life rarely actually want food. They rarely feel hunger. Excuse me. And often just the smell of food is nauseating. But that's hard because, like I said, food is love, care, celebrating memories, coping. We have to take cues from the patient. We have to know when to stop and to not force feed. So instead of feeding the body, let's feed the spirit. Do things like looking through a photo album instead of eating, comb their hair, massage their hands, listen to music together, say a prayer, read a book, tell a joke, bring a dog in, do pet visits, just feed the spirit, and you can no longer feed the body. Then you come to, because it's food that goes first, and people will still drink water, but then they no longer want water. Again, recognize the struggle, another loss. You know, mom went from not walking to not eating, and now she doesn't even want to drink. It's like loss after loss. In the meantime, we should be gently educating. And hopefully we've had this conversation a little bit more upstream, so it's not quite a shock. You can still offer hydration, offer it through a straw, offer it through a syringe, maybe with ice and without ice, offer iced chips. You can keep offering and they may take it and that's great, but if they don't force it. Because if you end up forcing or doing something like artificial hydration, the heart can't handle all that extra fluid and all of a sudden you start to see swelling in the extremities. Or it builds up in the lungs and you get short of breath because the heart cannot handle all that extra fluid. The other important thing is to provide good oral care for somebody. And even if their mouth is dry, IV hydration or artificial hydration is not going to stop their mouth from being dry. Use mouth swabs, keep it clean. Some people even swab Pepsi or whatever the person loved on there. I've had people swab whiskey, whatever, on their mouth swab to just kind of coat the inside of the mouth. Again, Tani, I love her. The only thing harder than talking about dying is not talking about it. I wholeheartedly believe this quote. Truly authentic communication happens during this incredibly sacred time. I love you, I'll miss you, I'll be okay. Sometimes when the family member remains in denial and tells the patient, you're gonna get better, you'll be okay, the patient hears that they're not ready for me to leave and they hang on, even though they may be ready. I love you, thank you, I forgive you, you forgive, please forgive me, are the four things that book by Dr. Ira Bayaka had. And not all closure is pretty, but all closure is important. So how can we help as professionals and non-professionals? Above all else, remain calm and be self-aware of your own biases towards a situation. So imagine a scene where a patient, a hospice patient is symptomatic and the family is just in absolute chaos. As a clinician, I walk in and I start to run around and be like, okay, we need to do this, we need to do this, I'm adding to the panic. But even if I feel a little panicked underneath, I need to walk in and remain calm and act like I've seen this before, because we're going to fix it one thing at a time. My calm demeanor will instill a sense of calm in the room. We have to respond with simplicity and compassion. You don't have to say something super inspirational to somebody who's grieving or to somebody who's dying. Sometimes responding with a touch of a hand, with acknowledgement that this situation sucks. Recognize the struggle. This must be hard, or I can see how hard this is. Offer support and be specific instead of, and I see this all the time, call me if you need me. What can I do for you? Can I do anything else? Ask, can I get you a glass of water? Can I go do a load of laundry for you? Can I come over and sit and watch a movie with you? Can I get you a tissue? Sometimes just sitting in silence in front of someone can be very powerful. They might not be able to cry or show weakness in front of their family because they feel like their family's grieving too. But if you as a stranger allow them, it can be very therapeutic. Even if the patient is in the coma, you can get the family to talk, ask open-ended questions, tell me your favorite story about mom. This can lift the energy in the room. And because people smile when they tell these types of stories. And this also allows mom or the patient to hear how she's going to be remembered. And usually once you get the family to start sharing these stories, you can back up a little bit and they'll keep talking. And I've been in the ICUs with patients hooked up to every monitor you can imagine, but comatose. And they'll hear a family member because hearing is the last to go. And I see their heart rate and their blood pressure instantly jump because I know they heard them. So keeping that environment positive, trying to normalize the experience for whoever's there, all of that is helpful. But I think the most important thing is remembering that you don't have to respond with some inspirational, earth-shattering quote. Just respond simply and with compassion. Don't be timid in your approach. Show confidence in the process that you can help normalize this experience. I already talked about how each kind of status loss of independence, loss of home, loss of ability to eat and drink, each loss is another loss for the patient and the family member. And all of those changes result in fear, and fear is very powerful, right? Allow them to grieve each of those losses. And instead of saying things like, well, I know you're going to a nursing facility, but at least you'll be safe there. At least you'll get 3 meals a day. Maybe encourage them to express about how they feel about that loss of independence and how it's hard for them. Any sentence that begins with, well, at least, it ultimately is dismissing or discounting the emotion behind what that person is feeling. My biggest piece of advice for somebody who is in the room with somebody who is dying. If they are already actively dying and comatose, they're no longer a fall risk. Put the bed rails down. Put their hands on top of the bed sheets so they are accessible. Remove those physical barriers. If you feel like those loved ones are timid to touch, you go touch the patient first. Give them permission. Show them that it is okay to touch this person's hand. This is their time. Sometimes we have to be the first one to talk lovingly to the patient, even though they're comatose, and show that that's okay and normal. Or we have to be the first one to hold the hand of the dying. But the family will almost always follow you. You're showing them that this is normal, this is okay, and you're giving them permission. You're ultimately helping them with the closure and the acceptance in this moment. I always tell people to talk, touch, hold, and always explain to the person, even if they're in a comatose, what you're doing and why. For these CE programs, I always end with our mission statement. And then my next slide has references, medical references for all of the stuff that I talked about. But I will unshare my screen. How do I do with time for this one? Oh, not too bad. Any questions about death or dying?
Yeah, we do have a question in the back, Sarah. Go ahead.
I wondered if you're familiar with an organization called Compassion and Care, which is advocating that people have the right to die on their own terms, like in Oregon and other states that have passed this.
Yeah, I know what you're talking about. So that's called physician aid in dying or physician assisted dying.
And is there any indication that there's any movement on this in the state of Ohio?
Yeah, so it's legal in I think 7 states now: Washington, Oregon, California, Colorado, Vermont. I was actually in Washington when it became legal and had a patient ask for it. That's where my first nursing job was out in Seattle, Washington. And I had a patient ask for it. And as the nurse, I was like, let me get the doc because this is beyond my wheelhouse. It had just become legal. The state of Ohio is very, very far away from that being legal anytime soon.
There's no movement at all.
I'm sure there is out there. But I know right now they've been fighting about what's called a post, which is physician orders for life-sustaining treatment and medical orders for life-sustaining treatment. And that's been repeatedly rejected and sent back. We have just very conservative views on right to die and things like that in Ohio. But in those other states, you have to have one or two physicians certify that you are of sound mind before you can get those medications. And then not only are you of sound mind, but you do have a terminal diagnosis. But my personal opinion, I don't see it coming to Ohio anytime soon.
Thank you, Sarah. I think we have a question in the back as well.
I also wondered if it would be all right to ask my father if he knows he's dying. This is another thing we said to his dad.
She wants to ask her father. I heard if it's okay to ask my father.
If he knows he's dying.
If he knows he's dying.
If he knows that he's dying? I mean, I have found in my experience, people appreciate the bluntness and being truthful. Now, I don't know your dad. I got to imagine he knows he's dying if he's dying. And there's got to be some denial and some sort of fear there, if that makes sense. Fear, like I said, is a huge motivator. One way that I often try to bring up death and dying to people is if you're sitting in a room with somebody and you see like a news story about a car accident or maybe there was a death in the family at some point. Oh, hey, do you remember when Uncle so-and-so died and it was kind of messy towards the end there? What would you have done in that situation? Just casually trying to bring it up with media stories or personal stories. It's not easy to bring up, especially with a parent, because that relationship has always been the parent sort of telling you, even though you're an adult, right? And now you're trying to help them or care for them. I got to imagine that he already knows. If I knew him a little better, I could maybe give you an example of how to bring it up, but I feel like I need to know the person.
I'm not afraid to ask him. Because he is, but I know my mom and my sister pretend that he's not.
That's our culture. That's what we've been taught. We've been taught to deny death from the beginning, right? That's society in America and culture. I mean, it's getting better though. It's getting better. People are getting a little bit more comfortable talking about it. I would just say one of the things that I say to patients is, what do you understand about your current condition? And then I have them say to me their functional status, or sometimes they bring up tests and they'll say, well, the answer to this test means this to me. Whether it's right or wrong, by asking them that open-ended question, what do you understand about your condition currently? You get a real insight as to how much information they've absorbed from the doctor and how much they understand about themselves. So what do you understand about your current condition?
Thank you, Sarah. Any other questions? Denny?
Hi, Sarah, Denny Barrett, how are you?
Hi, Denny.
On your list of signs that death is approaching, one of them was discoloration of the skin. What color are you talking about?
So usually the color changes in the skin are happening it starts in the knees, maybe in the feet or the hands and the elbows. And you'll see this red, ruddy, like lace-like appearance. That's called mottling. And that is lack of oxygen to the extremities because the blood's shunting away from those to go to the heart, lungs, and brain. If that starts to get worse, the lack of oxygen and lack of nutrients in those extremities will cause it to go from like a red ruddy to like a purple blue. And cold temperature changes at that point too, because those extremities aren't getting the blood supply to stay warm and oxygenated. So the changes in colors are always dark red, ruddy, or purple bluish. I've seen black before, but that's specific to like a wound. I mean, that's necrotic tissue. That's not, black is not normal, but there is necrosis could be. But it just depends on the patient. But normal would be red, ruddy, or blue to purple.
Thank you. I've got one more question.
Yep.
I take naps now in the afternoon. Is that a bad sign? Am I getting close to dying?
No, you're doing what your body needs, which is the nap in the afternoon.
So I have to leave pretty soon.
Well, we'll wrap up so you can nap.
Any other questions from anybody online today? No? All right. Okay, I have a question up front here.
I wish I'd written it down, but there was a, when you were presenting stuff at hospices about, intervening in interdisciplinary.
Mhm.
What does that mean?
Oh, that's a great question. So interdisciplinary was Dame Cicely Saunders' term because she realized that that picture of total pain, not just one discipline of medicine, meaning a doctor or a nurse or a social worker, can effectively assess and treat all of those different types of symptoms of total pain. That's why it needs to be an interdisciplinary team. So the disciplines are physician, nurse, social worker, spiritual caregiver, aide, and volunteer. All of those are a discipline within a team. So it's just saying that, like, you can't just have one nurse and doctor team taking care of a terminal patient, because even though I can recognize emotional pain, psychological pain, spiritual pain, practical pain, I'm not trained to assess and treat all of that. My training is involved with the physical symptoms of recognizing, assessing, and treating the physical stuff. So I need the social worker, the spiritual caregiver to help me out with those other things that I'm not trained for. So that's why it's an interdisciplinary approach.
Oh, I thought it was just, they've been bad and we're not reacting right.
You bad children. I love it.
Yeah.
Thank you, Sarah.
Yeah.
Well, on behalf of the Wood County Committee on Aging and all of our sponsors and supporters of the Care Compass Project, we thank you for presenting for our caregivers today, and we look forward to additional resources in the future.
All right. Yeah. Call me anytime. It was my pleasure. Thanks so much, guys.
Thank you.